all yours.
Great, thank you, Maddie. And thanks to everybody for joining this afternoon. There couldn't be a better topic in 2020 to start global health grand rounds for this academic year than COVID-19. So let's jump right in. So these are the data as of this morning. You may have seen this map. Johns Hopkins updates it on a daily basis. And this really illustrates where we are today with COVID-19. As you can see, there are 29 million cases described across the world and 188 countries and regions. As you know, the word pandemic means an epidemic that affects every region of the world. And as you can see from the map, COVID-19 is an excellent example of a pandemic. In the bottom right, you see the daily cases really coming out of nowhere in March and then continuing to go up. As a matter of fact, yesterday was the highest number of cases ever reported in one day worldwide. Over 300,000 new cases of COVID acquired just yesterday, and that set a new record. When you look at the list of countries affected over on the left, you see us at the top. 6.5 million Americans have been infected with SARS-CoV-2, the agent that causes COVID-19. You can see India is the #2 country, Brazil #3, and Russia #4. And then if you glance down the list, you see additional countries from South and Central America, as well as Europe and Asia, are represented. When we talk about deaths, the figures are really quite sobering. You can see globally over 900,000 people have died of this infection. And right here in the United States, 194,000 deaths. The #1 state in terms of burden of death from COVID-19 is New York. And 33,000 New Yorkers have died of COVID-19. While that's the older news about New York, the newer news that I think everybody knows is that things are much better here in New York State and in particular New York City. And here's some data. Again, these are from this morning, published by the New York City Department of Health. Here are the cases of COVID-19 in New York City. The first case was described in March 1st, and then you could see the peak was by about the second week in April, with over 6,000 cases occurring on a daily basis. And then you can see that number subsiding through April and May, achieving a relatively low level in June, and that's persisted since that time. So June, July, August, and into early September, the number of cases has been lower. While hospitalizations follow cases, and that's shown for you here, and you could see again, the peak in hospitalizations was around the second or third week in April, and those have trailed off nicely to very low levels over the last 3 months. And then behind that would be deaths from the virus. And again, you see a similar curve reaching low levels by June, July, August, and into September. And actually one day this weekend, New York City had zero COVID deaths. Here is a breakdown by zip code. This is the 5 boroughs of New York City. And the color code is the case rate per 100,000 population. And so you do see some striking differences right off the bat. The most heavily affected areas shown in purple, northern Queens, parts of Brooklyn, and parts of the Bronx have been most heavily affected. You can see Manhattan here is relatively lighter color with some variation in the neighborhood. Here's our zip code, which you can see is relatively lower caseload than other parts of Manhattan. Here's the latest New York Presbyterian numbers in terms of COVID cases. And I draw your attention to the bottom, which is the whole hospital system. So all the hospitals together. An important milestone reached when the number of inpatients fell to less than 100. There's 22 patients across the enterprise, so all the hospitals together, in the ICU, and currently only 17 intubated patients. And then if you scan down the list, you'll see us. So 20 inpatients currently, with 6 on ventilators. If you compare that with the second week in April, which was our peak, we had close to 500 inpatients and over 200 people on ventilators. So obviously substantial progress has been made. How did that happen? Well, this shows the concept of bending the curve, which was a successful strategy in New York and much of the Northeast United States. Well, let's take a step back and talk about the causative agent, the virus that causes COVID-19, which, as you know, goes by the name SARS-CoV-2. It's a member of the coronavirus family. These are enveloped, single-stranded RNA viruses, and you can see corona pictured over on the right. It gets the name corona, which means crown, because of these spike structures. You get the feeling that these are a bit like a crown on top of somebody's head, and that's why they're called that. They're divided, coronaviruses, into 4 genera that go by the Greek letters, alpha, beta, gamma, and delta. And coronaviruses do share properties with other single-stranded RNA viruses. Many of these will be familiar to you: dengue, Ebola, hepatitis C, HIV, rhinoviruses, which of course cause the common cold, and West Nile virus are all examples of single-stranded RNA viruses. Coronaviruses in general cause respiratory, gastrointestinal, hepatic, and neurologic diseases. And these are common in animals like camels, cattle, cats, bats, and birds, as well, of course, as humans. The new coronavirus, SARS-CoV-2, is the 7th member of the coronavirus family known to infect humans. The first 4 were known for quite some time, and these go by the letters and numbers you see listed here. And they cause a relatively mild respiratory disease. So about 10 to 30% of upper respiratory infections in any one season are caused by these older coronaviruses. They were thought of as mild viruses, not causing substantial disease. That all changed when SARS, the original severe acute respiratory syndrome virus, CoV standing for coronavirus, appeared in 2002 and caused cases of respiratory failure and severe respiratory disease. Well, it was 10 years later when another coronavirus known as MERS, which stands for Middle East Respiratory Syndrome, emerged. And here we are now with the 3rd coronavirus, which can cause severe disease. Again, SARS-CoV-2, the causative agent of COVID-19. Well, this is a phylogenetic tree which shows the relationships of these 3 coronaviruses which cause severe respiratory illness. So they're all beta coronaviruses. Here in orange is SARS-CoV-2. And what you can see from the relationship here, it's very closely related to a bat coronavirus. In fact, the 2 share 96% of their genomic sequences. When you compare SARS-CoV-2 with the original SARS-CoV, shown in blue here, you also get the sense from this tree that they are quite closely related, and in fact share 79% of their genetic sequence. Lower down and more distantly on the phylogenetic tree is the MERS, Middle East Respiratory Syndrome coronavirus, and these 2 share about 50% of their genetic sequence. Here is the genome and structure of coronaviruses. A typical coronavirus has a genome of about 30 kilobases. And there are 4 structural proteins, as shown in this diagram, and these go by letters of the alphabet. N is nucleocapsid, so that encases the genetic material, the RNA. M is the membrane protein sitting on the surface of the particle. E is the envelope protein, and S is the important spike protein, shown for you here. Again, the protein that gives coronavirus its name. And then there are non-structural proteins coded for by the genome. There are two separate proteases. These are enzymes that cleave proteins, a helicase, and then an RNA polymerase, which the virus uses to reproduce itself. You can isolate SARS-CoV-2 from the lower respiratory tracts of people with COVID-19 pneumonia. And originally, that's how this virus was discovered. There was a cluster of pneumonia among family members in Wuhan, China. They came to public health attention. They obtained specimens from them and sequenced and visualized the virus by electron microscopy. And this was published in the New England Journal. And here's the electron microscopy. This is the viral particle. You can see those corona-like projections on the surface of the virus. It's thought that this was a single introduction into humans, likely from an animal contact, followed by, as we well know, human-to-human spread. And the evidence for that is a high similarity in the sequences from different human patients. This suggests very recent introduction into humans. As you know, the first cases in China were described only in December of last year. We now know that there are at least 8 strains of SARS-CoV-2 circulating globally, and they're distinguished by minor genomic changes. In fact, there's only about 11 mutations seen in this 30,000 base pair genome between the different 8 strains that are currently circulating. In terms of clinical virology, this novel coronavirus, as mentioned, seems to have emerged from a bat origin. And it's postulated that this reached humans by contact with an intermediate source. The animal is known as the pangolin. And there it is. If you think it looks like a dinosaur, well, yeah, it does. It's been a very popular pet in China and often sold as an exotic pet. And so it's thought that bats came into contact with pangolins, and it may be that humans acquired this virus by contact too, although it's not known with certainty. There was an epidemiologic link in Wuhan, China, to a particular seafood wholesale market, and some, but not all, of the original cases were linked to exposure at that market. As mentioned, SARS-CoV-2 shares some features with the original SARS, or SARS-CoV, including the cell entry receptor, which is known as ACE2, and sits on the surfaces of many human cells, including respiratory epithelial cells, which is how this virus gains entry into the human body. Coronaviruses, unlike other viruses such as influenza, are much less likely to mutate, and that explains why so few mutations are seen now worldwide. What about the clinical presentation of COVID-19? So we know that this virus, being a respiratory virus, is transmitted primarily through respiratory droplets from one human to another. This virus may be aerosolized and transmitted during certain activities. One of the most notable is singing, and there have been outbreaks that have been attributed to choirs who were practicing together, or procedures in the hospital, such as intubation or the use of nebulizers to give certain medication. The role of aerosols in transmission continues to be under active discussion. We know that many people who are exposed to this virus may be asymptomatically infected, and some will be pre-symptomatic in that they will go on to develop symptoms. And we know that viral load levels in the respiratory tract are very high immediately prior to developing symptoms. So asymptomatic people can be a source of infectious virus. In fact, it's estimated that 40 to 50 or even more, as high as 80% of cases, may be people who have no symptoms at all. And as mentioned, the nasopharyngeal viral levels just before or soon after symptom onset are their highest for the entire disease. This is in contrast to the original SARS, where it took at least a week for the viral load levels to achieve high levels in the respiratory tract. The incubation period, that is the time between infection and the development of symptoms, is an average of 4 to 5 days, and it's estimated that nearly all who develop symptoms will do it within 12 days of exposure to the virus. What we know about COVID, we know from the original description from China. So here is the initial large description of what was going on with the clinical cases of COVID-19 in China, published in the New England Journal. This is based on over 1,000 laboratory confirmed cases from over 550 hospitals in 30 different provinces. And you can see the median age of these 1,000+ people was 47 years. Men were more affected than women, with men just under 60% of the total. And the most common symptoms in this group were fever, cough, fatigue, and GI symptoms, including diarrhea, were relatively less common. What we know of the clinical course really comes from the original Chinese experience, and this has been duplicated now worldwide. Roughly 15% of people will develop severe disease, and some of the risk factors for that are older age and comorbidities, including common diseases like hypertension, diabetes mellitus, and coronary artery disease. A less percentile, 6% in this case, will go on to respiratory failure and require mechanical ventilation, or in rare cases, ECMO. And acute respiratory distress syndrome will develop in approximately 3.5% of people. The mortality from COVID in people who don't recover is about 1 to 1.5%. Well, we put together our own statistics right here at New York Presbyterian Weill Cornell. Colleague Parag Goyal from the Division of Cardiology put together a database of our patients here at Cornell. And you can see this was published in the New England Journal on approximately the first 400 people admitted to our hospital. You'll note some similarities with the Chinese group and some differences. Our patients tended to be a bit older, so the average age was 62. We did see the male predominance, with about 60% of men were men, as opposed to about 40% in women. In terms of risk factors, we did see some of the same ones that they did in China, but note obesity was actually described as one of the risk factors for New Yorkers who developed COVID. About 36% of our patients here at Cornell were obese, and that was particularly true in people under the age of 40. The CDC now lists groups, people with comorbid illnesses, who are at increased risk of developing severe illness from COVID-19. One of the most recently added was cancer, not originally appreciated, but now known to be a risk factor. Chronic kidney disease, pulmonary disease like COPD or chronic obstructive pulmonary disease, immunocompromise from transplantation, obesity showing up on the CDC list now, heart conditions such as heart failure, coronary artery disease, and cardiomyopathies, sickle cell disease, and as mentioned, diabetes mellitus. The clinical manifestations, the earliest ones in symptomatic disease, are common upper respiratory type symptoms: fever, cough, sore throat, malaise, and myalgias. Gastrointestinal symptoms were seen more frequently in American patients than Chinese patients for reasons that aren't really clear: anorexia, nausea, and diarrhea being the most common. As you've heard, taste and smell disturbances have been linked to COVID, although these are relatively uncommon. And then the most common complication early on is shortness of breath. And that develops an average of about a week after the first symptoms have come on. In terms of lab findings, a decrease in the total lymphocyte count is quite characteristic. elevated liver enzymes, and then elevated inflammatory markers such as D-dimer, LDH, CRP, ferritin, and interleukin-6 levels may be increased in COVID-19. Again, the most common complication is seen in terms of pulmonary disease. And so you see radiographic findings here. Here's a chest x-ray consistent with mild or moderate COVID pneumonia, and you can see increased markings here on both sides. The CAT scan in that patient also shows bilateral infiltrates, and you can see it's labeled here non-severe. In more severe cases, you can see more extensive infiltrates both on chest x-ray and again on CAT scan. Here is the spectrum of disease that we see with COVID. Again, asymptomatic and pre-symptomatic infection, people who test positive but have no symptoms at all. Mild or moderate disease is characterized by the constellation of symptoms of any upper respiratory infection. Moderate illness is characterized by oxygen levels in the blood, so oxygen saturation of 94% or more, in the presence of documented lower respiratory disease like pneumonia. And either mild to moderate disease occurs in about 80% of people. As mentioned, about 15% will go on to severe illness, so they become hypoxic with oxygen saturations less than 94%, tachypnic with respiratory rates over 30 per minute, and lung infiltrates in over 50% of the lung fields. And then a smaller proportion, about 5%, will go on to critical illness, respiratory failure, shock, and multi-organ dysfunction. Together with colleagues in pulmonary here, we wrote a review of severe COVID, which was published earlier this year in the New England Journal. And this illustrates the time course of the disease. So again, someone infected at time -5 takes about 5 to 7 days to develop symptoms. Again, the typical symptoms here. And then another week to develop the complication of shortness of breath in around 40% of people. And then perhaps within 2 to 3 days, severe or critical illness requiring intubation and the risk for multi-organ failure. COVID-19, although it starts off as a respiratory disease, really can be a multi-system disease, and you can see the systems listed here. So not uncommonly, in addition to the respiratory findings, are neurologic findings, cardiovascular, renal, gastrointestinal, and characteristic skin findings. And then systemically, there is a whole sequence of events that's triggered by what's known as the cytokine storm. So essentially revving up of the immune response, which leads to dysfunctional responses, including inflammation and coagulation defects. Children typically have a mild illness, but it's been appreciated recently that COVID infection can cause a multi-system inflammatory syndrome known as MIS-C in children. This is an acute vasculitis, inflammation of the blood vessels, with similarities to a disease called Kawasaki's disease. And it's characterized by conjunctivitis, red and cracked lips, some lymphadenopathy, and a skin rash. And it can go on to be quite serious, causing a post-infectious hyperinflammatory syndrome, which has led to death in a small number of pediatric patients. More recently, cases have also been described in teenagers and even adults in their early 20s. Well, let's talk about testing. The direct test for the presence of the virus is a nasopharyngeal swab for SARS-CoV-2 using a PCR technology. We're now running at this hospital up to 2,000 tests a day, and testing is readily available. In fact, all patients admitted to the hospital here are tested for SARS-CoV-2. This is also available to outpatients, particularly those coming in for a procedure, and it's available to healthcare workers, both symptomatic and asymptomatic. Well, that's a direct test for the presence of the virus. We also have testing more recently available for antibodies to SARS-CoV-2. It's important to know that antibodies do take a finite amount of time to develop. The range here, 2 to 17 days. Most people say 7 days or longer after infection is when antibodies can be detected. We do have assays right here in our laboratory, and they can do up to 2,000 antibody tests a day. One of the questions right now is, how do you use antibody testing? Well, you can identify people to donate convalescent plasma. I'll say more about that as we talk about therapy. Sometimes we use this for diagnosis in a rare case where PCR for the virus continues to be negative despite a high degree of clinical suspicion. And then we can use this to screen either healthcare workers or patients. It says here for immunity, but we don't actually know if an antibody to this virus confers immunity, and that is an open question. Here is a diagram of the diagnostic tests for SARS-CoV-2, and let's start with the PCR. So shown in blue is the nasopharyngeal, so upper respiratory presence of the virus. Again, we're looking at out about 1 to 2 weeks, you can begin to detect the virus before symptoms have developed. That's what the dotted line shows for you, the time of symptom development. And as I emphasize, these are the highest levels of the virus you'll see with this disease. After you keep detecting the virus for weeks, or even in some cases for months later. That doesn't mean that what you're detecting here is intact virus. It simply may be pieces of virus that turn positive with the PCR. In pink is the lower respiratory, so this would be specimens from bronchoalveolar lavage, and you can see it parallels the upper respiratory, but may be detected at higher levels later in the course of illness. In orange is actually getting the virus out from the respiratory tract, and importantly, again, the highest levels are right around the time of symptom onset, but we now have good data to show that after 10 days from symptoms, people no longer have intact virus that they're excreting in their sputum or that can be isolated at all. And we use that fact to tell us when people can be taken off isolation. A healthy host will not have intact virus 10 days after developing symptoms of COVID-19. That's different from someone with immunocompromise or who has been ill longer, such as people who are intubated in the ICU, and they can excrete intact virus longer than that. Yellow shows you stool positive for PCR. Again, not clear if that could actually transmit the virus to another person. And then in the dotted lines are the antibody responses. IgM shown in purple, IgG shown in green, but you can see they parallel each other, begin to be detectable about 7 to 10 days out, and then reach peak levels by week 3 or 4. And we actually don't know how long these antibodies can be tested. There's at least some evidence to suggest that after 12 weeks, some people lose their antibody responses. Well, what about treatment? Where are we with treatment of COVID-19? To understand how we approach it, you need to understand the clinical course of disease again, as shown on this diagram. So someone's infected at time 0. As mentioned, it takes 2 to 7 days to develop symptoms. And during that time, the viral loads, the SARS-CoV-2 viral load increases sharply. At the same time, the lymphocyte count in the blood declines. So it takes about a week in some proportion of patients who will develop more severe disease. And this is characterized by the cytokine storm, the inflammatory response, coagulation changes, and respiratory failure. That can progress to respiratory distress or ARDS and require intubation. And then in some patients that will progress over time to death. So this diagram helps us think about how we might intervene to treat or manage COVID-19. This is a viral disease, so antivirals would be one way to approach it. And we know from other respiratory infections like influenza that these have the most effect if given early on in the illness. The cytokine storm is also a target for therapy. So immunomodulators, compounds that can dampen or decrease the immune response, could have an effect in COVID-19. Once you get tissue damage, there may be other kinds of therapies that could promote tissue repair, and these are being explored as well. And then finally, could we prevent this whole thing from happening? Are there compounds we could administer to people who are exposed or at high risk? And these are all ways that people are looking at interrupting the clinical course of COVID-19. The NIH publishes treatment guidelines. These are available. Here's the web address across the top. These are kept incredibly up to date. I'm really proud to be one of the co-chairs, along with two colleagues of mine from the NIH. So if you're interested in the latest in COVID treatment, I refer you to these. Well, it's fair to say today, in September of 2020, there are no FDA-approved treatments, and the current standard of care is evolving. The backbone is supportive care, oxygen, medications to lower fever. Bacterial co-infections are actually initially rare, although can complicate ICU stay. But there are many candidate treatments, and some of these have been well studied. Antiviral agents like hydroxychloroquine and remdesivir, immunomodulators, a host of them, antithrombotics, and then, as mentioned, cellular therapies. So let's talk about some of these. The guidelines, first of all, recommend no specific treatment for people who are asymptomatic or pre-symptomatic. So there's no proven therapy for that group. They also say there's insufficient data to recommend any antiviral or immunomodulatory therapy in someone with mild illness. When we think about antivirals, we think about the life cycle of SARS-CoV-2, and that's what's shown for you here. So here's the virus over on the left. You can see the spike proteins on the surface of the cell. And in big blue here is the target cell. In this case, it'll be the human respiratory upper epithelial cell. It has an ACE2 receptor as part of its membrane, and that's what the virus recognizes and binds to in the first step called viral attachment. TMPRSS is a protease that's incorporated in the cellular membrane, cleaves proteins, and is involved with the second step, which is membrane fusion and endocytosis. So the virus is brought inside the cytoplasm of the cell. In the next step, it uncoats and exposes its viral RNA into the cytoplasm, which is used for two things. One is it's transcribed by a viral enzyme to additional copies of viral RNA. And the other is it uses the cellular mechanism to translate viral RNA into viral proteins. So the viral proteins and the viral copies of RNA come together and assemble, migrate to the surface of the cell, and then are released into new viral particles. And many of these will be fully capable of starting this process all over again in the next cell that they meet. So the way to use an antiviral would be to interrupt one or more steps of the viral life cycle. We have candidate compounds which can inhibit fusion, inhibit the protease inhibitors, inhibit the polymerase, or interfere with nuclear export of proteins. The one antiviral that has shown a clinical effect is a compound called remdesivir. This is an investigational antiviral agent, not approved yet by the FDA. It's an RNA polymerase inhibitor, and it shows activity in the test tube and animals against SARS, MERS, and SARS-CoV-2. This compound was tried for Ebola in more than 500 people who were in a clinical trial. It didn't work well for Ebola, but it did give us a safety record for remdesivir in human subjects, and it was generally well tolerated. So people turned to this when COVID came along. The original published clinical data was through a program called compassionate use, which did not have a control arm, however, was followed by a large randomized study sponsored by the NIH called the ACT-1 study. And I'll show you the results, the positive results of that on people with severe COVID-19 in the next slide. This prompted the FDA to grant access to remdesivir across the country in something called an emergency use authorization. That is something the FDA uses to make an investigational treatment widely available if it shows the promise of efficacy. And additional studies were done that supported the result. So the best study of remdesivir is shown for you here. This is a phase 3 multi-center randomized double-blind placebo-controlled study. So the best evidence we have that a treatment works. The target population were adults hospitalized with COVID with evidence of lower respiratory tract involvement, so pneumonia, and over 1,000 patients were entered. They received either remdesivir or a placebo for 10 days, and the endpoint was time to clinical recovery. And what did they find? Well, what you see here is the proportion who improved of the two groups. And you can see in blue, more people who took remdesivir improved compared with placebo. Although it's notable that over half of both groups actually got better. But this was statistically significantly better, favoring remdesivir. When they looked at subgroups, an interesting fact came true, and that was the group that was hospitalized and receiving oxygen actually had the best responses to remdesivir. Not quite as good were people receiving high flow oxygen or who are actually mechanically ventilated. And in this group, actually, there was no statistical difference between remdesivir and placebo. The conclusion overall is that remdesivir was superior to placebo. This was the first compound to show efficacy for COVID-19. That led the guidelines to say, for mild to moderate disease, insufficient data with remdesivir, but for people who required supplemental oxygen, the panel recommends remdesivir. For sicker people, those who are ventilated or on ECMO, the panel said there is uncertainty and cannot make a formal recommendation. So the group that benefits the most, apparently, is those on supplemental oxygen. There's new formulations. So remdesivir is an intravenous medication, but they are trying subcutaneous, so injectable or inhaled remdesivir. And a colleague of mine from India sent me this. So they are already making generic remdesivir in developing countries. And he's used this in patients in India. Well, what about hydroxychloroquine? Well, that was a drug that's FDA approved for malaria and autoimmune diseases like lupus. We know it has antiviral effects as well, and it's active against SARS-CoV-2 in the test tube. And it modulates the immune system. That's why it works for diseases like lupus. So it was readily available, had test tube data. Why not try it for COVID? And that was explored early on. Lots of case reports, cohort studies, even small clinical trials. But the data were really conflicting, and there was some potential for cardiac toxicity. There were at least 4 large retrospective studies that found no benefit from our colleagues at Columbia, all around New York State, in the Veterans Administration. And look at the last study published in The Lancet, over 14,000 patients. But don't look too long at that publication because it was later withdrawn because they could not corroborate the results. Interesting lesson for us. Things are going so fast in COVID that even major journals will publish a manuscript that can't be corroborated and had to be withdrawn. Well, even a personal testimonial came out for hydroxychloroquine. This was a Twitter post. Hydroxy and an antibiotic called azithromycin taken together have a real chance to be one of the biggest game changers in the history of medicine. Personal testimony. I was on call this day in the hospital, and you can bet a lot of patients asked about this and their families. Well, it turns out we now have randomized clinical trials, and hydroxychloroquine does not work for COVID. This is a Brazil study. There's a UK study, and they randomized hospitalized patients to get hydroxychloroquine or not. Hundreds to thousands of patients, there was no difference in clinical outcomes or mortality. Well, perhaps that was too late. They looked at earlier stages of the disease, so a US study and a Spanish study, people who were not hospitalized with milder cases. Again, hydroxychloroquine versus placebo or no treatment, no difference. So that led the guidelines panel to say that we recommend against hydroxychloroquine for COVID-19. Well, what about immune-based therapies? Could you administer antibodies that could neutralize the virus either outside of the cell or inside the cell? The concept of convalescent plasma has been around for a while. That is, you take people who've recovered from a disease, isolate their plasma with antibodies inside, and hope that that could benefit someone else. And that's been used for influenza, the original SARS, MERS, or even Ebola. There are some potential risks of this approach, but people were enthusiastic about looking at this for COVID-19. And in fact, there's been 3 randomized clinical trials, one from China, one from the Netherlands, and just recently one from India. The Chinese study was stopped early because the epidemic essentially went down or disappeared from China. In the Netherlands, they found out that antibody titers in their patients were just as high as convalescent plasma, so they decided to stop their study. And then the most recent study in India that randomized over 460 people to get convalescent plasma or not did not see any difference in disease or mortality. In this country, there were lots of retrospective matched cohorts which seemed to suggest benefit, and that led to a program sponsored by Mayo Clinic where literally tens of thousands of patients who are hospitalized for COVID received convalescent plasma. Now, they did substantiate that the safety of this approach seemed to be there. The reactions were less than 1% overall. But they had no control arm. So we really don't know, was this an effective approach or not? Nevertheless, the FDA controversially developed an expanded use authorization for convalescent plasma on the grounds that it may be effective. And they caution that it does not yet represent a new standard of care. What we really need are randomized controlled clinical trials to tell us if convalescent plasma works. I'm pleased to tell you that we're doing one right here. You can see the maple leaf. It's a Canadian-sponsored study of convalescent plasma or not. And my colleague Marshall Glesby in infectious disease is leading that study here. We're actively enrolling. We actually enrolled someone yesterday. The guidelines say there are insufficient data to recommend convalescent plasma. And then we get to cytokine inhibitors. So as mentioned, COVID or SARS-CoV-2 provokes a cytokine storm. It's shown for you here. Lots and lots of cytokines are in the circulation and cause inflammation and disease. So could you interrupt or abrogate that? And people tried. So interleukin-6 antagonists targeting that cytokine. One called sarilumab, initial reports suggested benefit, but the randomized clinical trial did not. There was no improvement. And its cousin tocilizumab, again, retrospective studies and case series suggested benefit, but the large phase 3 studies showed no efficacy. So this approach now recommended against. People are trying a lot of other approaches, interleukin-1 antagonists, and borrowing from oncology, BTK and JAK inhibitors. And in fact, just this morning, there was a press release saying baricitinib combined with remdesivir seemed to have some effects, but we wait for those data. And I mentioned cellular therapies to promote cellular repair are also actively in clinical trials. Lastly, what about prevention? Well, again, no proven preventative drugs today for COVID-19 and no FDA approved drugs either. The current standard for prevention, it's hand washing, masks, social distancing, droplet precautions in the hospital, and personal protective equipment. But people are exploring some of the drugs used for treatment. Could they prevent COVID-19? Antivirals, convalescent plasma, or hyperimmune globulin, and then of course, vaccines. So where are we? Well, hydroxychloroquine. Again, it was around, it was available, it seemed to work in the test tube. Could it actually benefit by preventing COVID-19? And again, a personal testimonial. May 18th, Trump says he takes hydroxychloroquine to prevent coronavirus infection. Well, what's the data? Here's the data. A US and Canada study that looked at people within 4 days of exposure to individuals with COVID-19. These were healthcare workers, randomized to hydroxy versus placebo. You can see over 800 people. Bottom line, no difference in preventing COVID. Side effects more common with hydroxychloroquine. And then more recently, a Spanish study, much larger, 2,300 people, same results. So no difference in incidence of confirmed symptomatic COVID, no difference between hydroxychloroquine and usual care, no difference in transmission of SARS-CoV-2, adverse events more with hydroxychloroquine. There are a host of pre-exposure prophylaxis. So this is aiming at people, particularly healthcare workers, who might become exposed. And we don't yet have data on this group. But the guidelines say they recommend against any agents for post-exposure prophylaxis based on the data I showed you, and pre-exposure prophylaxis except in a clinical trial. So we need more data. Well, lastly, vaccines. More than 200 SARS-CoV-2 vaccines have been discovered, and at least 8 are in the final stage of development. We are participating in the first large phase 3 study of a corona vaccine trial right here at Weill Cornell. This is a phase 3 study. It's going to enroll close to 30,000 people who will either receive the vaccine or placebo, and the vaccine requires 2 injections 28 days apart. And the primary endpoint is developing COVID. So this study is actively enrolling as of now, and over 20,000 people nationally have been put on this study. There's at least 7 other big phase 3 studies that are going to come in the next couple of months to our unit and to units across the country. In conclusion, there are no currently approved treatments for COVID-19, but the investigational antiviral remdesivir showed clinical benefit in hospitalized patients on oxygen who were not yet intubated. I didn't share the dexamethasone data, but that was the first drug to show a mortality benefit. Dexamethasone is a type of corticosteroid, so effectively abrogating the cytokine storm. Additional therapies are under study for treatment. There are no approved preventatives for COVID-19 today. However, people are exploring antivirals, antibodies, and vaccines. Again, there couldn't be a better example of a global disease today in 2020 than COVID-19. And I just want to acknowledge my colleagues here at Weill Cornell and a whole bunch of people who loaned me slides for this talk. And I put my email in the lower right-hand corner. Thanks for your attention. I hope I left a lot of time for questions because I'm sure there are a few.
Thank you, Dr. Gulick. That was really eloquent, clear and concise. And I want to thank you for, launching our Global Health Grand Rounds. Any questions from the group, please? Use the chat, and Dr. Gulick will be more than happy to to answer them. So feel free to chime in.
So I'm seeing one. It was addressed privately to me, so thanks for that. What's the story with COVID, and I think you mean SARS-CoV-2, the virus, being modified in a laboratory? So COVID is an opportunity for conspiracy theories, which you can find plenty of if you go onto the internet. People early on developed a story that this was manufactured in a lab in China and then released into the population. That seems implausible. It's actually been looked at pretty carefully and found not to be true. This virus was isolated from bats or a related virus in bats in the Wuhan area. So it's much more likely that, like other diseases, it came through animals to people and then spread widely. Let's see what else I got.
I think you have some more.
Okay. Can you comment on why some patients do not develop antibodies and how it's related to T-cell immune response or other responses?
There you go.
So first of all, if you're not speaking, you might want to go on mute because we can hear you. It's true that some people do not seem to develop antibodies, and some people develop very low titers of antibodies while others develop high titers. And we don't know yet why that is. It looks like people with more severe disease, as you might guess, develop higher titers of antibodies, but it's not generally consistent. We also know that all antibodies are not necessarily predictive. So we're looking for high titers of antibodies, which could be neutralizing to really do the trick. And then your other question about humoral response, which means antibody response, versus T-cell response. And again, we don't know what's important with this virus. What helps people fight it off? Is it antibodies, or is it T-cells, or is it a combination of the two? And so we're still learning. Here's another one. Good question from Lola Brown. Is there any data to suggest a second wave? And some people have argued that we've already seen the second wave. If you look what happened in the United States, of course, we were the epicenter at the beginning, and then it was confined to the Northeast. And then when states began to reopen prematurely, we saw new epicenters in the South and the West. Most recently, the cases in those areas are going down. We're now seeing increases in Midwestern states. I guess, though, what you really meant is, are we going to see a resurgence here in New York City? And no one really knows. We're all holding our breath. I think watching and looking back at that data I showed you, that for 3 months we've been able to contain it, and that Cuomo announced over the weekend that it's now been 36 days that the incidence of COVID in terms of being in people who are tested is below 1% over the last 36 days. So no one really knows for sure about whether we will see a resurgence. We're all anxiously awaiting that. Europe has had a bit of a second wave, but again, is it truly a second wave, or is it simply tied to easing of restrictions? And it looks like it's the latter. Has there been any studies looking into genetic predispositions? That is a great question, and we don't know yet. Why are Latinos and African Americans more likely to be hospitalized and have severe COVID? We don't know the answer to that yet. Why are men more affected than women? We don't know the answer to that yet either. But people are beginning to look at this. It's an active area of research. Can you talk about reinfection of previously recovered patients and the implications for treatment? So this was hotly debated for a long period of time, and the initial cases that were described probably weren't reinfection. They were probably just prolonged infection. And as I mentioned, you can detect PCR even in people who have recovered. You can detect PCR evidence of the virus. That doesn't mean transmissible virus. But recently, and this made the news, there's been several cases of people who have been known to recover and then were infected with a second strain of SARS-CoV-2, which differed from their initial infection. So it is possible to be reinfected with SARS-CoV-2. We don't know how common it is, but it's there. And then you go on to say, what are the implications for treatment? Or I would say, what about prevention? Is a vaccine really going to work if people can get reinfected? Might they lose their antibody or their cellular responses? We don't know. Let's see what else. So a question about if antibody levels do decline after 12 weeks, what does that say about the implications for vaccines? That's a good question. But simply said, if your antibodies decline, that doesn't necessarily mean that you couldn't make them again if you were challenged by the virus again at a later time point. So just the fact that you can't detect antibodies at a future time doesn't mean you still might not have a protective response. And we won't know until we test. And so that will be answered by these large vaccine studies. Is there data following protest marches or political rallies? And the answer is yes. I guess the most recent evidence was the Sturgis rally, motorcycle rally in South Dakota. And if you remember the pictures, there were literally tens of thousands of people, very few who used masks, coming from all over the Midwest for this motorcycle rally. And it made the press, and many people were saying, I'm not going to use a mask. They now have linked both cases and even deaths to motorcycle rally. You know, our president just held a rally in Las Vegas over the weekend, and most people were not wearing masks. The governor of Nevada said he thought that was a very irresponsible thing to do. And I would chime in and say that, yeah, why are you doing that? It was a closed environment, tens of thousands of people from all over the area, very few wearing masks. It's a setup for transmission. This virus is readily transmitted by close human contact like that. So disappointing. I guess I'm reassured by some of the political marches, particularly here in New York. I've been on a few myself, and people wear masks. So if you're going to march, please wear a mask out there and use the precautions. Let's see. Can you speak to the concept that immunosuppressed individuals might be at lower risk because they wouldn't necessarily mount the same cytokine storm reaction? People have postulated that, and there was some talk as to whether HIV somehow was protective, either because people were on medications that could be protective, or perhaps this concept that if you're immunosuppressed, you don't mount as much of a cytokine storm. Well, I think that for the immunosuppressed part of it, that's really been debunked. So we know that actually having cancer or on chemotherapy or being a organ transplant patient on immunosuppressants increases your risk. So it's an interesting idea, but it hasn't really borne out that way. Another question, is it possible the vaccine could induce a more severe syndrome due to cytokine storm? And that is a possibility. We see that in dengue virus infection. If you remember, if you get vaccinated for dengue, you can actually have a more severe outcome if you're re-exposed to dengue. That has not been seen with this disease, but we're in the early stages. So I guess we don't truly know the answer to that question yet. How are we doing on time, Maddie? Am I okay to keep going?
I would say that for those who wish to stay on, absolutely. And for those that need to go, we appreciate your joining us. And I personally, Dr. Gulick, Roy, thank you for your comments. So we can continue as long as you feel you want to. But, for those that need to go, we're at the bewitching hour of 6 o'clock. I thank you for joining us. So we can go for another 10 minutes, let's say, and see where it takes us.
So it's the days of COVID. It's not like we have anything else to do, right?
Right.
I don't
No
have
more
dinner.
cinemas.
I don't have dinner reservations outside. So I'm happy to keep going with some questions.
Okay, so
Okay, let's see.
we'll let it roll.
Share your thoughts regarding the incidence of patients with multiple negative nasopharyngeal PCR tests despite a high clinical suspicion. Is it believed to be a result of decreased viral load in the nasopharynx? So that's a nicely worded question. I've seen a couple of cases of this. The most compelling one was a patient who was in our medical ICU, and 30-year-old Latino guy who looked all the world like he had COVID disease. He was intubated on the respirator. Multiple PCRs were negative. He had a brother with confirmed COVID who he lived with. So his brother was PCR positive. So why couldn't we isolate it? And the thinking goes along the lines of the question. Initially, it's your upper respiratory tract that has the virus. As the disease progresses, it tends to move lower. So it's lower respiratory tract. And early on, the tests weren't as good at picking up the virus in sputum or bronchial alveolar lavage fluid. So this particular patient I mentioned, I think we got 5 negative specimens on him. And eventually we got an antibody test and it was positive. So it confirmed the diagnosis. These are uncommon cases, or you could even say rare. In fact, we put our cases together for publication. That's how unusual that scenario is. My friend Alavi Sas is asking me, so he's asking about minority infection rates and are minorities being well represented in COVID research? And that's a great question coming from Alavi, and it's really important. I mean, clinical trials show you what to do, but they need to represent the people that are getting sick. So you want to have good representation from Latinos and African Americans, and for this disease, people over the age of 65. You want to make sure all those groups are well represented. This has really come up on our vaccine study. And being in New York, of course, we can really reach out to lots of different communities, and we have been successful. Nationally, there's been some criticism that not enough people of color are represented on some of the studies. So there is an active initiative out there to make sure that we're reaching all the communities that are heavily affected. Any updates regarding speculative ACE inhibitor or ibuprofen association with more severe courses of COVID? So ACE receptor, as mentioned before, is the one that COVID binds to on the surface of cells. And so if you used a common medication for high blood pressure, an ACE inhibitor, could that actually improve or make COVID worse somehow? Well, that's been carefully looked at. Turns out it has no effect. So taking an ACE inhibitor really doesn't affect the course of disease. And then non-steroidals were also implicated early on, but no, that hasn't panned out either. So neither one is thought to be related to the severity of COVID disease. What's the diagnostic performance of nasal PCR? So there are some groups that are trying to develop more friendly COVID tests. If you've had the nasopharyngeal swab, you know that they insert a very long swab through your nose to hit the back of your pharynx. I've had more than one patient describe it as a brain biopsy, but it's not. It's uncomfortable just for a moment, and then they get a good specimen. So people are looking at, could you do a nasal swab, just sticking in the tip of the nose, or could you do sputum? And those tests are under evaluation, but not yet validated. Let's see. If you have a question, I'm going to make sure I got them all. Please put it in the chat.
No, I think the questions were terrific. Oh, we have flu season coming up. Yeah.
Aha. I'm hearing people commenting they will not take the flu mask since they're required to wear a mask anyway. will you please comment? I worry that you can be exposed to both and that may be catastrophic. I share your concern there. So having one respiratory virus is bad enough. Having two, we just don't know what might happen. So I would encourage everyone to get the flu shot this year, and the CDC is as well. Let's try to avoid the flu, not only for the purpose of avoiding two viruses together, but also just in terms of diagnostics. If you take flu off the table, it'll be easier to diagnose COVID. If we have both together, that may cause some confusion. Obviously, you don't want people presenting to emergency rooms who don't have to be. So let's avoid all the flu we can this year. I already got my flu shot, so I would encourage all of you to get one too. Having said that, the Southern Hemisphere is 6 months ahead of us in the flu season, and South Africa is a country that has been hard hit by COVID and had a big flu outbreak, or at least they thought they might. But interestingly, the number of cases of flu this year in South Africa is way down. Why is that? It may be because we're taking such good precautions for COVID. That's the same way you would avoid exposure to flu, right? Washing your hands, social isolation, wearing masks. So think of the flu vaccine as just one more way that you can avoid that. So everybody get your flu shot this year, please. All right, let's see. Less sensitive, quicker COVID tests may be better for epidemiologic tracking to follow active infections versus detecting residual nucleic acids with PCR tests. That's an interesting idea. I think for epidemiologic tracking, you really just want to have widespread testing. And then you try to do contact tracing if it's not a widespread epidemic. I don't know that the less sensitive, quicker tests, I mean, theoretically that could add to it if they were rolled out. I'm not aware that that's happening right now. All right.
Well, I think that that they've exhausted you, but your answers were consistently spectacular, on point. And again, want to thank you so very much for giving such an eloquent talk. Thank you really very much for that. So
thanks for inviting me.
And thank you all for joining us. And stay safe, wash your hands, wear a mask, etc. And I agree, get a flu shot. Okay. Thank you all so much for joining us.
Okay.
Trip, thanks so much.
Thanks.
Cheers.
Bye.